let's look at. Let's look at our assessment of the medical patient. When you think about looking at a trauma patient and looking at a medical patient, how are you going to do your assessment? What's significant about a trauma patient that you don't see with a medical patient? Their injuries. Usually with a trauma patient, you can look at them and say, oh, your leg's hanging off. Oh, blood squirting out of your head. Your head's cut off. Yeah, usually with a trauma patient, it's fairly simple to determine their mechanism of injury and what their injuries are. With a medical patient, all bets are off. It's going to come down to your ability to be a detective, your ability to ask the right questions, and then with that information, figure out a differential diagnosis. And we'll talk about that as we go along too. So we're going to look at the difference in this chapter between a responsive medical patient and an unresponsive medical patient. What's the difference between an unresponsive medical patient and an unresponsive trauma patient?
You don't know what's wrong.
Yeah, really nothing. I mean, we don't know if they're unconscious. We don't know if it's completely a medical problem, right? If it's a trauma patient, we can't be sure they don't have a medical and a trauma going on. So if they're unconscious, kind of all bets are off. But probably 90% of your medical patients are going to be conscious and relatively alert, so we can get a lot of history from them. We're going to also look at a secondary assessment on a responsive patient. So things change once we have a responsive medical patient as far as how we assess them. If we've got a responsive trauma patient and a responsive medical patient, who are we going to have to spend more time interviewing? The medical patient. The trauma patient, you've got a mechanism of injury. I mean, how difficult can it be? With a medical patient, well, when did you take that pill? How long has this been going on? What started it? What does it feel like? You've got a whole host of things to find out. With a medical patient, you're bleeding. Okay, trauma patient, you're bleeding. Cover that up. How's that? Better. Good. Let's go. So we're going to look at a secondary assessment of the medical patient because that's different, and we're going to compare the two assessments. Responsive versus responsive. Unresponsive. Responsive is going to depend on your interview skills as to how well you do at figuring out what's wrong with your patient. If they're unresponsive, it's going to depend on your physical assessment. So any unresponsive patient is going to be your physical assessment, which is going to be DCAT BTLS, right? It's going to be your primary assessment, your rapid trauma assessment. In fact, on a unresponsive medical patient, we essentially do a rapid trauma assessment. Although we don't call it rapid trauma assessment, we just call it a rapid assessment. We're doing the exact same thing. We're looking for what's going to kill our patient, what could be going on. With a responsive patient, in our secondary assessment, we're getting history of present illness. So that's basically what's going on with you now, what started it, what led up to it, what does it feel like, where does it hurt, what are you taking for it, has this happened before, how did you treat it when this happened before, how long ago was it, on and on. Past medical history. That's going to be significant past medical history. You're going to do your focused exam. If they're a conscious medical patient and they say, I've got chest pain, am I going to focus on their ankle? Am I going to look down in their ears and, palpate their head and stuff? No, because they have an isolated complaint. I have chest pain. So we're going to focus our assessment on their chest pain. So if they're a responsive medical patient, you should be able to get a good history of present illness as well as a good past medical history. You'll do your focused exam. If you've got a patient that says they have chest pain, what's going to be your focused exam there? What are the three things we do? We palpate, auscultate, inspect, right? So yeah, we'll say they've got chest pain. Well, do you know if it's cardiac chest pain or if it's musculoskeletal chest pain? You're going to have to do more assessment. So you're going to listen to the lung sounds. You're going to palpate. Probably going to grab their chest and say, take a deep breath for me. Does that hurt when you breathe? That sort of thing. That's going to be your focused exam. You're going to do that based on their chief complaint. And of course, you'll get your baseline vital signs. Remember I showed you on those sheets, baseline vital signs is pretty far down the sheet. That doesn't mean you have to wade through everything before you do that. It means if you've got a partner working with you, while you're at the top part of the sheet, you can say, get me a set of vital signs. The sooner you get them, the better, but they're not as important as your physical exam is and your history of present illness. Those types of things are really more important than your baseline vital signs. So if somebody's here that can get them, get on with it. So your history of present illness, most of the time you're going to get that from your patient. It's possible that your patient has an altered mental status and they can't give you the history, so you may have to get it from family members or bystanders, but you may also get it from other areas. Like they may have a medical alert bracelet on. You may suspect that they are diabetic. You might see insulin in the refrigerator. You may look around. If they've got a whole bunch of medications at the bedside, you might start looking at those so you can get a picture of what's going on with your patient. By looking at their medications, it's going to tell you pretty quickly what they're suffering from. Not maybe at that specific time, but as far as their medical history. When you're interviewing a patient and asking them about what's going on with them, you want to try to use open-ended questions. What that means is no yes and no questions. Like, does your chest hurt? What are they going to say? Yeah. Does it hurt right here? Yeah. Does it feel like an elephant sitting on your chest? Yeah. Yeah, they're going to answer yes to everything. So when you're using closed-ended questions, they're going to respond with what they think you want to hear. But if you say, describe your chest pain to me, you know what you're listening for, but they don't know what you're listening for most of the time, unless they've called VMS 1,000 times and they know what you want to hear. But yeah, so if you say, well, describe your chest pain to me, what might they say? What might they say, Ben?
Feels like an elephant sitting on my chest.
Feels like an elephant sitting on my chest. What else might they say? Cindy?
I have a sharp pain in my heart.
Yeah, it's like a sharp stabbing pain. But if you said to them, do you have a stabbing pain in your chest? What are you going to say? Yeah, it really hurts. Yeah, so whenever possible, you want to open-ended questions so they describe to you what they're feeling rather than you suggesting things for them. Now, there will be some cases where if your patient is extremely short of breath, like they can hardly breathe, you're going to have to abbreviate that. They're probably not making that up. So you may ask them some short, quick, closed-ended questions just to get right to some answers there. But most of the time you're getting open-ended questions because you're going to know based on what your patient tells you, it's going to lead you down a path of what's probably wrong with them. And as we go through the semester, we're going to start working on our medical and trauma assessments in the lab. And it's probably one of the hardest things for students to learn is to ask really good questions. And the questions that you ask really are determined by your critical thinking ability. Because you're trying to put together a picture of what's going on. How many of you guys ever work with puzzles? You know, when you have to put the pieces together? A few of you? You know, those are great critical thinking exercises where you don't see the big picture, you see little pieces, and you have to see how pieces fit together. That's basically what you're doing with a medical assessment. You're putting a bunch of seemingly unrelated pieces together and making a picture out of it. So your history of present illness is going to be based on their chief complaint. I have chest pain. And they're usually going to tell you whatever's bothering them the most. A patient with chest pain may have other things going on that may be related or not related. But you won't know until you start asking questions. Now we've done the sample history. There's this next mnemonic, OPQRST. OPQRST is another one that you need to be familiar with. Did somebody send me an email reminding me to bring this sheet? I have a sheet with these mnemonics on it for you. To remind me to bring that, somebody. Okay, OPQRST is your history of present illness. O is onset. What were you doing when it started? Well, I've got chest pain. What were you doing when your chest pain started? I was mowing the lawn. Now, we'll find out that that's significant. Doing some physical exercise when chest pain starts versus laying up in the easy chair with your feet up having chest pain. That's going to lead you to a couple different things. provokes? What makes the pain worse? Also, P is palliates. I don't know if I can spell that. Does that look right? Palliates. Palliates, what does that mean? You know what palliative is? Palliative is comfort measures. So if you've got a patient, say you have a headache, you take an Excedrin, that's a palliative measure. You've taken that to alleviate your pain. So provokes or palliates, what makes it better or worse? So if I've got chest pain and I say, is there anything that makes it better or worse? He says, well, when I sit down and rest, it stops hurting. That's what palliates or provokes is. That's what the P is. Q, quality. Describe the pain. Now, if I just said describe your pain, I might also say, tell me what it feels like. That's what I was saying. You don't want to say, does it feel like an elephant sitting on your chest? They're going to go, yeah. You want them to describe it to you. That will tell you what's going on more than you trying to tell them what to say. So tell me what it feels like. Radiation. Where is the pain? Does it stay in one place or does it move? Chest pain, for example. They may say, well, it feels like an elephant sitting on my chest, but I also have pain in my shoulder and down my arm. Or I may have pain that goes up into my neck. Sometimes patients may say it feels like a toothache. Some may say it radiates to the back. So that's important that you know that. S, severity. With severity, we're looking for a number, 1 to 10. How bad is the pain on a scale of 1 to 10? With 1 being really no pain at all, hardly any, to 10 being the worst pain you've ever felt. Is this going to be consistent for all of your patients? Have you ever known anybody that's just a baby? I mean, if you barely touch them, and it hurts so bad. Then others can chop their fingers off and go, what the heck, didn't need that finger anyway. Yeah, everybody's going to feel it. Everybody's going to feel a little bit differently. What we're looking for here with this 1 to 10, we're also looking, just like we do with our vital signs, we're looking to see if there are any changes. We're looking for trends. So if initially they tell you that their pain is 7 out of 10, and then 15 minutes later they say it's 3 out of 10, have they gotten better or worse? Yeah, they've gotten better. So it's going to vary patient to patient. You can have somebody that same chest pain would be killing one person, and the other one says it feels like a 3. Well, you know that guy with a 3 is better, for now he tells you it's a 1. So it's relative. But it's a 1 to 10 scale. And it's not just pain, but it may be respiratory distress. If you've got a medical patient and they're having difficulty breathing like this, he may determine that I was better before you got here and I'm getting worse. Or he may say it's a 7 out of 10, and you put them on oxygen, you calm them down, you put their feet up, whatever, you sit them up. And now they say it's a 4 out of 10, they've gotten better. So that 1 to 10 scale, you always want to get a numerical value from every patient, as long as they're conscious. Time. When did the pain start? 10 minutes ago. That's different than onset. Onset is what were you doing when it started. Time is when did it start. Okay? Y'all gonna be able to fill this out if we have a quiz at the end? No. No. What's O mean? Onset?
Yes.
What's onset?
What
What were you doing when it started? P? Provokes. What makes the pain better or worse? Quality? Describe the pain. What does it feel like? Radiation? Where is it? And is it moving? Severity? Scale of 1 to 10. How bad is it? Time? When did it start? See, y'all got that. Okay, past medical history. This is important because a lot of people are in this cycle thing. You've had it once, you've had it again. We talk about febrile seizures in pediatric patients. A febrile seizure, who knows what that is? Who's had one? What is it? Yeah, a seizure caused by a very high or spiking fever. That's a febrile seizure. So if your child's had one febrile seizure, he's at a much greater risk of having subsequent febrile seizures. So with past medical history, you want to find out what's been going on that's related to what's going on today. So symptoms, allergies. Now, signs, we've already gotten that, right? So we're not asking about signs. We're asking about symptoms now. What are your allergies, medications, pertinent past history, last oral intake, events leading up? What does that look like? Sample history. Yeah, we just had that, right? Good work. Okay, tailoring your past medical history. Sometimes you get a patient with diarrhea of the mouth. You know, you ask about their past medical history, and, you know, I had toenail surgery, you know, because da 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 da, and, you know, I had a grudge under my toenail. They pulled, you know, you don't need to hear that, and you have to be tactful sometimes so that your patient's not taking up all your time telling you stuff you don't want to know. But if you can tailor your questions to the patient's chief complaint, then you can get a better idea of what's going on with your patient. Ask questions that are pertinent to the complaint. Why did you have your tonsils out? Would that ever be a pertinent question? Yeah. If you've got somebody with a really bad sore throat, you know, it's inflamed in there, you might ask, have you had your tonsils out? It's just like you got somebody, you're wondering if they could be pregnant. What would you want to ask? Do what? Yeah, I mean, if you possibly had a hysterectomy or something, that would be important. Sometimes you might use the body systems approach, where you basically focus your question and answers your questions based on the body system that's involved. For instance, how many of you guys have older grandparents and people like that that have like CHF, congestive heart failure? You know anybody with that? Probably quite a few of you. So if they are having an episode, they might have chest pain, but can you think of any other body systems that might be involved there? When they have a flare-up of their CHF, do you know what else happens there? Yeah, it very commonly affects the respiratory system. They may have pulmonary edema, where when you auscultate, you hear fluid in the lungs. They may very commonly have swelling around the ankles. So those are different body systems that if you'll assess those, it'll point to something that kind of takes you down that path. So you want to focus on what you think is going on and go through those body systems that might be involved. Now with a kid, when you're trying to get a good history with a child, if they're over about 4 years and up, they usually can give you a pretty good history. Not, you know, what was going on with you when you were 2, but history of current illness, they may have a pretty good idea there. Younger than that, not so much. But if you ask them simply, you know, and here you might not so much give those open-ended questions, but you might ask them, does your chest hurt at all? Yeah, it does hurt. You also get information from the caregivers. Okay, if your patient has whatever their chief complaint is, I've got chest pain, you're going to do a focused assessment on that area, right? On the trauma patient, who do we do a focused assessment on? A focused assessment. Focused assessment. Not significant. They just have an isolated complaint. I twisted my ankle. Similar to the medical assessment. You know, their complaint is, in most cases, something, my chest hurts. I have trouble breathing. My stomach hurts. Those are isolated things, pretty much, where you're going to focus your exam on that particular area or system. Usually this physical exam is pretty brief. With your medical assessments, it's usually not this whole body assessment thing. It's not like the trauma. Most of your information from a medical patient is going to come from what? Your patient. When you're doing your interview, that's where you're going to find out what's going on with your patient. I mean, you might do a physical exam. Like here, of course, you're going to auscultate. Anybody with respiratory problems or cardiac problems, you're going to auscultate. But you're not going to do a full body touchdown on this thing. You're going to examine the area specifically that the patient's complaining about. If he says he's got abdominal pain, yeah, I'm going to look at that. I'm looking for what? What am I looking for when I look at the abdomen of a medical patient? BTLS. I'm going to look for that even though it's not a trauma. I'm going to look to see if there's any bruising. I'm going to look to see if it's tender. I'm going to palpate it. Is it firm? Is it distended? You know, does it hurt? Do they have any rebound tenderness? So I'm going to do a physical exam of whatever the area is that they specifically say is a problem. We're going to get our baseline vital signs. Vital signs with a medical patient, you want to get them as soon as possible, but they're still further down the list too. Where would you focus your physical examination on a patient complaining of shortness of breath? The chest, yeah, we're going to auscultate, certainly. We're going to look, we're going to palpate. Put your hands around the rib cage. Take a deep breath for me. If it hurts when they take a deep breath, that's going to point you on a different direction than pulmonary edema. So do a good focused exam on your medical patients. An unresponsive medical patient is going to be assessed like whom?
Unconscious trauma.
An unresponsive trauma patient or a trauma patient with a significant mechanism of injury. Now your secondary assessment on your unresponsive medical patient, that comes after what? Our rapid assessment, right? We'll do our initial assessment, our ABCs. We'll do our rapid assessment. We'll make our transport decision. Once we're en route, now we're going to do a secondary assessment, which means we're going to palpate them all over, right? It's essentially an assessment on a trauma patient. So if they can't talk to you, you've got to treat them like a trauma patient. It's going to begin with a physical exam and your baseline vitals. So if they're unresponsive, you can't do that interview. If they're responsive, medical patient, how are you going to get your information? Interview. If they're unresponsive, how are you going to get it? Physical exam. Right. Get history wherever you can get it. Your rapid exam is going to be just like your rapid trauma exam. Head to toe, palpate everything, and it's pretty fast. If they're unresponsive, what does that tell you about how bad they are? Yeah, they're pretty bad if they're unresponsive, so we're going to move with haste. Main difference is you do not assess the face during the rapid trauma exam. Otherwise, it's going to be the same. Important physical findings. Now, for a medical patient, if you're doing your rapid exam, you check the neck. What's JVD? Talked a minute ago. Jugular vein distension. If you look at them and their veins are sticking out, particularly if they're sitting up and their veins are sticking out, that's a real problem. When they're laying down, they may get some normal backflow, but still, if they're engorged or enlarged, you have a problem. Look for medical identification devices. Look at their billfold. See if they're carrying something that says, you know, they have an issue. You know, I've had a heart transplant. Great, love that. Chest, you're going to auscultate breath sounds. You don't know what's going on with that patient. You're assuming that it's a medical. Hopefully somebody in the family there has called 911 and you know what's going on, but may not be. You've got to check breath sounds. Abdomen, you're going to palpate it. You won't be able to tell if it's tender, but you can tell if it's rigid or if it's distended. You're going to check the pelvis. What you're looking for here is incontinence, and that's a word you need to know. Incontinence means they've lost control of either urine or bowels. Most commonly, you're looking at urine, but you know if they've lost control of their bowels too, they're in pretty sorry shape, aren't they? Can you think of any time that you very commonly see people who are incontinent of urine? Seizure in particular. Yeah, most of the time if people have a patient has a grand mal seizure, they're very commonly incontinent. So that's something you always want to look for. As soon as you see they've wet their britches, you're going to start thinking first, they've had a seizure. That's probably or likely reason that they're unconscious. You're going to check their extremities. You're checking for pulse. You may not be able to get motor or sensory if they're unconscious, but you might. They might not be profoundly unconscious, but if you run your fingernail up the bottom of their foot against their skin, you may get a response there. You want to also check their pulse oximetry reading. You're going to put a pulse oximeter on there. What's your oxygen saturation? All these are important physical findings that you may or may not see. Now you may have to decide if you're going to call for ALS backup. You know, hopefully in this area you'll be riding on an ALS ambulance, and that won't be required. But there will be times where you'll have to make a decision, do I need ALS here or not? You know, if you're working on a BLS fire truck, you know, you may be able to handle that. If they're unconscious, I'm calling for backup. And you may make that decision based on their vital signs. If you took their blood pressure and it was 60/20, does that freak you out? Yeah, it freaks me out. I'm going to call somebody else. Help, help. History of present illness or past medical history. If they're unconscious, it's going to be hard to get. You ask anybody you can find. If you're at an office building, coworkers may know something. You know, you may look in the refrigerator, you may see ID bracelets, something, whatever you can find. Try to find out from the bystanders the patient's name. You may not have that information. Hopefully they can tell you what happened. Did you see anything? For instance, they saw, you know, somebody flying by the window, or, you know, what happened? Well, they flew past this window. Well, now I know they fell quite a ways. Did you see, were they doing it? Have they been up moving around normally in the last half hour? No, nobody's seen him for 3 hours. He went in his office and never came out. So all that's important information that you may be able to get from bystanders. Did the patient complain of anything before this happened? You know, if the patient's unconscious, you ask the family members, well, what was going on before this? Did they complain of anything? Yeah, I remember this morning at breakfast, Johnny said that his stomach really hurt. You know, now they find him unconscious upstairs. You know, what's happened? Does the patient have any illnesses or problems? Past medical history. Is the patient taking any medications? Sometimes bystanders may not know that. You may have to actually scavenge through a medicine cabinet or something. What other mechanisms might you have to obtain, that you might have to obtain patient history other than speaking to bystanders? There's no people that can give you information. How else can you gather information on a medical patient? What might be on the driver's license? Yeah, it makes, you know, that will tell us what's wrong with it. Somebody cut his heart out. I'm just giving you a hard time. How else could you get information? Yeah, if they've got a medical identification bracelet, what else? Yeah, look at the medications. Look in your refrigerator. Look around. You know, if they've got 3 meds sitting right by their glass of water, they may have taken an overdose of something. So you've got to really zone in on those medications if you can't get any information. Comparing assessments, responsive medical patient. These are going to be, most of your medical patients are going to be responsive. You'll do your primary assessment. Usually it's pretty easy on a conscious medical patient. What is your primary assessment? Give me, what's the top of the sheet of the primary assessment? Do what? General impression, exactly right. Yeah, what's their low responsiveness? Their chief complaint. You're going to do all that on your responsive medical patient, right? If they're talking to you and they're coherent, what do we know about their level of consciousness? Pretty good. We ask them what their chief complaint is, and they say, gosh, you know, my chest has been hurting me. I had a patient one time. I said, well, tell me what's going on. Why do you call 911? He goes, well, my chest hurts. Well, how long's your chest been hurting? 20 years. Okay? That gives us a starting place. So in our primary assessment, we've done those first 3 things. Your chief complaint, general impression, level of consciousness, chief complaint. What's next? Yeah, ABC, airway. If he's told me he's had chest pain for 20 years, what do I know about his airway? It's open. He's talking to me, how's he breathing? If he's talking with no distress, breathing's good. So we move on to circulation. How are you going to assess circulation? You're going to touch them. And when you're touching them, what are you touching? I know my hand's breathing. What are you checking? Checking the pulse. And what are we looking for specifically in pulse? Is it fast, slow, or non-existent? Is it strong or weak, regular, irregular? Good work. So we check all those things. What's the last part of C? Even though it's more related to a trauma patient, but we're still going to check for blood. Yeah, skin signs. We didn't talk about the color, did we? We were talking about the pulse. Checking skin signs. What are you feeling with checking for skin signs? I'm going to have to check it again. What am I checking for with skin signs? Temperature, warm, cold. Condition. Condition is what? Oh, brain fart. Condition? Wet or dry. Yeah, we're getting there. And what else? Yeah, what does it look like? Is it pink? Is it yellow? Is it white? Is it pale? What's going on with it? So those are going to be your skin signs. So we've done, is that all of our primary assessment? What do we miss? Transport decision. So now based on what we've seen with our patient, we're going to make a transport decision. See, pretty good. Y'all are getting this. We've done our primary assessment. If the patient is alert, they don't have any life-threatening problems, then we can take our time, right? We can do further assessment. We'll do our secondary assessment. What is our secondary assessment? Actually, I don't like secondary assessment there. What are we really doing here before we do our secondary assessment? It's not on here. It starts with an F. Our focus assessment. That's exactly right. We're going to do our focus assessment on whatever they said's wrong with them. Oh, my stomach hurts. I've had diarrhea for a week. What am I going to say? I'm going to get my partner to assess you. I'm going to the truck. No, not really. So yeah, you're going to do your focus assessment. Get your history of present illness. How long has this been going on? What does it feel like? Remember that OPQRST? What does the O stand for? Onset. What does that mean? What? Right. What were you doing when it happened? P is what? What provokes or what's that other P word? Palliates. So that means what? It makes it better or worse. OP, what's Q? Quality is what? What does it feel like? Describe it to me. OPQ, what's the R? Radiation. What does that mean?
Where does it move?
Yeah, does it move around? OPQRS? Severity. And severity is what? 1 to 10. Scale of 1 to 10. OPQRST? Time. What's that? When did it start? Yeah, so all these things you're doing, that's your history of present illness. So past medical history, if I tell you I've got chest pain and I've given you all my OPQRST, what do you want to know about my past medical history? Has this ever happened before? Do they have a known heart condition? Yeah. Is there a problem that you're aware of, like open heart surgery? Yeah. What else would you ask? Yeah, you're going to get your sample history based on your past medical history too. I would want to know if I said yes. I would say, have you ever felt this pain before? Yes. What do I want to know now? Yeah. When was it? What was it? What did they do about it? You know, you've got somebody, say, with asthma. They're having an asthma attack. You want to know, have you ever had this before? Yes. Was it ever this bad before? Yes. Did you have to be hospitalized because of it? Yes. Have you ever been intubated before? Yes. Now what am I thinking? I'm thinking, let's get the hell out of here because I don't want to be here when you like pass out and die. So yeah, by getting that information from your patient, it tells you how bad that patient is. I mean, if they've been this whole thing before, they've had chest pain, they've been defibrillated, they've been brought back from dead 3 times, what are the chances are you're going to have to get your AED out? Pretty darn good. Asthma patient, if they tell you they've been intubated before, you better unroll your stuff because they're probably going to be intubated again. So yeah, past medical history is important because these things repeat themselves. If they got something going on, it's a very good chance they're going to get it again. So then you're going to pick up with your physical exam. And your physical exam is what kind of exam? Focused exam. Now if you've done all of that, you may go back and do a full exam, right? It's not necessary. Get your vital signs and then transport. And why do we get vital signs? Yes, so we can detect trends. Exactly. Unresponsive medical patient, we're going to have to do our primary assessment just like what kind of patient? Trauma patient, that's right. If they're not alert or their ABCs are compromised, we're going to have to do a rapid physical exam, which is just like what? Our rapid trauma exam, that's right. Get vital signs. Hopefully there's somebody there that can jump in and get those vital signs. Get whatever history you can get from the family and hit the road. You'll do your more detailed exam once you're en route. Okay, let's see. The history and physical exam of a medical patient, 2 forms. What are they? What 2 types of patients will we see? Responsive or unresponsive? A responsive patient will focus most of our time on what? Do our patient interview. If they're unresponsive, how are we going to glean our information? Our physical assessment. That's right. You're getting it. You assess a responsive patient by getting history of present illness. That's so important, coupled with their past medical history. We're going to do a focused exam. Since unresponsive patients can't communicate, we're going to treat them like what? Trauma patients. That's right. You may not change any field treatments as a result of your information, but you're going to pass that information along because you're setting a trend there. You're showing them this is the way the patient was. So it's important you're able to get all that information. Explain how long the history. Okay, you're trying to get information from a very upset son of an unresponsive man. His father's unresponsive, the son's really upset. He's the only available family member, but he's so upset he just can't hardly talk to you. So you can picture this. How can you quickly get him to calm down and give you his father's medical history? Yeah, get him out of that site to lower his stress level. Get one-on-one with him and say, in order for me to help your dad, I need you to calm down and give me some information. That usually works. Yeah. Y'all want a makeup exam? Okay, get out a piece of paper. All right, this is worth 6 points.
6 points?
6 points.